Hi, everyone. So I'm going to continue recording lecture for OB and GYN surgery. So this will be part 3. Part 1 and 2 were very short. Sorry about that. But I am recording after class here in the classroom. So that's why you see your female anatomy behind me. Just a reminder that if you need to review over some of that anatomy, it's here for you. So please use all the resources you have, including some of the posters and diagrams we have in the classroom if you need help with that anatomy. I will go ahead and share my screen. But again, we're on OB and GYN surgery. And the last thing I finished talking about was laparoscopic resection of an unruptured tubal pregnancy. So I did kind of get cut off at the end of that, but I didn't have anything else to add. So that was the end of page 530. So now I'm starting on page 532. So hopefully you have used this picture to help you study the ligaments and some of the anatomy. The rest of this anatomy, I don't have a lot of pictures for, but I need you to read through it so you understand some of the different features in GYN examinations and surgery. So looking at page 532, those are basic lab tests, physical examination, right? Let's look at 533. So as you read through these, you're going to read some different terms. I want you to pay the most attention to things that are diagnostic. So diagnostic tests, for example, that are going to help the surgeon come up with the diagnosis before we get to surgery. So there's so much different pathologies. Again, read through all of it. You can go to page 534. You read some of your symptoms of endometriosis. You're going to have many patients that you're going to help with that have endometriosis, and sometimes you can actually see it on laparoscopic cases. So the surgeon will point those things out to you. You actually learn a lot about anatomy when doing those laparoscopic cases. So that's just one example of some of the things that you're going to see in the operating room. You'll see some surgeries that are talked about later in the book that are used for diagnostic reasons. Example, on 534 again, let's go up to the top of the page this time. Find where it says endometrial hyperplasia. Endometrial hyperplasia. So signs are going to have postmenopausal bleeding, prolonged irregular bleeding, anemia. The diagnostic test is a surgery that we do. So D&C to rule out carcinoma. So we're going to do a dilation and curettage and take a specimen of endometrial lining to make sure it's not cancer. So that's an example of a case, a D&C, we normally do for a woman who's had a miscarriage. But in this instant, we're doing it to rule out carcinoma. So my point is, some of the procedures we do in GYN surgery are also diagnostic tests. That's what I want you to see as you're reading through all of this information on these green boxes. So now I want to take a moment to look at page 535. On 535, looking at uterine, cervical, and ovarian cancer. When you're looking at that section, hopefully you're seeing some terms that you're familiar with, like pap smear, endocervical curettage, like I've been talking about, endometrial curettage or biopsy, as I've been talking about. So you know they're going to do a D&C to get those specimens. So another example of diagnostic, even though it's a surgery that we do sometimes to help our patients for other reasons, it can also be diagnostic. Okay, look at cervical cancer. So cervical cancer, your book has these green boxes, right? It doesn't go through what all we do to treat cervical cancer. Very important for you to understand that. So if you're looking at cervical cancer, that section, I want you to highlight colposcopy. Colposcopy. Just want you to know the term and what they're actually doing. So this one is done in the office, and I have an image here for you so you can understand that we're basically looking at that tissue through a microscope. So this is a diagnostic test, and you need to know that term. So underneath colposcopy, look at all your different options for the cervix. So cervical cancer, you could do a cervical conization, a biopsy, a curettage, you could do a Schiller's test. There's so many different options for cervical cancer. So because you're going to do so much of it and your book does not go over the specific procedures, I've added in slides for you so that when you go out to externship and you hear the names of these procedures, you're not completely thrown off of your game. So there is extra information in this slideshow. Now actually talks about cervical cancer right there, but it talks about it again on the next page. So I want you to flip it over, page 536. Find where it says cervix again. So again, we're using the colposcope, doing a colposcopy so that we can diagnose. So we're trying to find out about their cervix if they have cervical cancer. So we've looked at it under the microscope with the colposcope. Now they've determined that tissue looks questionable. We want to take a biopsy. So you'll see throughout here, you can do cervical biopsies. This one says punch. So you've learned 2 of those instruments today in the classroom. So they take a punch of that tissue and send it to pathology so that we can get an answer on whether it is cancer or not, and exactly where that cancer begins and ends so that we can get the proper margins taken. So you'll see in your book your options. So there is endocervical curettage, cervical cold cone, a LEAP procedure, and then it goes through what to do with a cervical stump, but I will skip over that. What I want you to see again is that you can take a cervical biopsy here. So here is what I was talking about in class, where you're going to take that specimen and put it on TELFA. So they're going to send that specimen to pathology to get an answer of whether it's cancerous or not. So once we, if we know the answer with that punch biopsy, they could escalate and go to this cone biopsy. Another option is they did the colposcope. They understand where the cancer is and how involved it is, and they know they're going to take out a whole cone, as they call it. So find in your book where it says cervical cone, and then it says cold in quotes. So it says cold for a reason, and I'll separate the cold from the hot. So cold cone biopsy. So a large area of tissue around the cervix is excised for examination, and hopefully you understand the name now because it is cut out in the shape of a cone. So if you look on the right side of your page right now, the area cut out with a knife, laser, or electrical loop. So the reason it says cold right now is because we're not using a laser, we're not using electricity of any kind, we're just using a knife. That's why they're going to call it cold. So this one is done cold, and hopefully now you understand the name conization because we're taking a cone of the cervix out. So cone biopsy, be familiar with cervical cone as it says in your book. So cervical cone biopsy. After that, you'll see another option, the LEAP. So again, it says cervical cone, but this time it says LEAP on it. So your LEAP, your loop electrosurgical excision. This procedure is going to, of course, use that wire that you see for the electrosurgical portion. So this one is done hot. So they have no reason to write out hot. We only write out cold when we're not using any heat. So the LEAP is a very common procedure, and if you saw LEAP up on the board, I want you to know what it stands for. So you can impress your preceptor and tell them, I know what case I'm about to do. It's a loop electrosurgical excision. So then you know what they're talking about, and you can see they're still removing a cone-like shape of tissue. But we're doing that with the loop, electrosurgical loop. Okay, so now you know what LEAP is, and you know what the cervical cone biopsy is. So these are both done for biopsy. After that, I'm going to talk about one that it doesn't talk about in this section of the book. So cryosurgery is another option to help cervical cancer. So they're going to use nitrogen, so it's compressed nitrogen, so it freezes it. So it flows through the cryo probe, that's just the handpiece that they're using. It makes that metal so cold that it's going to freeze and destroy any abnormal cervical tissue. So this is a way to not only biopsy, but to treat. So this is destroying abnormal cervical tissue, cryosurgery for cervical cancer. So again, this is all stuff you have to add in here. Okay, so now that you understand the different ways that we're going to treat cervical cancer, we can move on through your book. I did not want you to miss out on all the different ways we're going to treat cervical cancer in the OR. I do want to go back for just a moment, though, to talk about safety. So for the LEAP procedure, or really any time that we are putting heat on something that's cancer, you don't want to breathe that in. So they do this with genital warts cases too. They'll use some type of electrosurgical unit, example like the LEAP wire, and they will take those genital warts off. The problem with that is the plume that is produced is in the air, and we can breathe that in. As you know, we use the suction to suck up the plume, but you can't get 100% of it, right? So you're going to wear a special mask when you are in these cases. They usually use laser masks, and they have more of a filter on it, and I know you learned about that during the laser portion of ST1228, but these cases also, you're going to want to wear a special mask. So you don't want to breathe in any of that tissue. So same thing with cervical cancer. They believe that if we are putting heat on this and it creates a plume, that if we breathe that in, we could then get that inside of us. So with genital warts, they actually do have proof of that. We have had people that work in the operating room have that in their throat, and that's from the patient that they were around. So what I would like is for you to have that in your mind and always treat these cases as a dangerous case where you should protect yourself. So if you can get a special mask to protect yourself better on these cases so that you're not breathing in that plume that you shouldn't be breathing in. Okay, so that's all I've got on cervical cancer for sure this time. So after that, it goes into more procedures, but I want to read what's in your book first. So ignore the slide for just a moment. Let's look at page 537. So it goes through all the abdominal incisions for GYN. You should recognize a lot of this from general surgery. So you'll notice that everything builds on general surgery. So hopefully this is building on top for you, and parts of it are review. As you're looking through the incisions, pay special attention to transverse, Van and Steel, Maryland, and the Cherney incisions. Those are ones you're going to want to be familiar with. After that, it goes through diagnostic procedures. So example right here on the slide, hysteroscopy or a laparoscopy could be diagnostic. So just another reminder for you, we could go in and do a laparoscopy. So that's inflating the belly with CO2 using a camera and a light cord to check out what is going on. That could be diagnostic. We could also be doing a laparoscopy for fill in the blank with whatever the surgery is. So laparoscopic tubal ligation, example. So be prepared that any laparoscopic case, it could be a designated case or it could be diagnostic. To me, that always meant anything could happen. We could go in and just diagnose, or we could go in and see something that we need to take care of. Depends on the consent that was done with the patient. They love to throw in "and all indicated procedures" at the end so that it can cover the different things that they might encounter during the case. But again, diagnostic procedures, no laparoscopy and hysteroscopy as options for diagnostic procedures. On 538, it goes through those three that I wanted you to focus on: Van and Steel, Maryland, and the Cherney. As you're going through them, I want you to focus on muscles that you're going through. So example, the Fan and Steel. You go through the skin and sub-Q, of course, and then after that's incised, you get to the level of the anterior rectus sheath. That's very specific, but it wants you to know that. So know that specific anatomy that you're getting through. Okay, so it talks about the anterior rectus sheath and the anterior rectus muscle that is incised. So pay attention again to those muscles as you go through. After that, let's look at basic laparoscopy. So as I said before, this could be diagnostic or it could be a specific test. What I like about this section is that it has so many pictures for you. So this is all a review of laparoscopic. So basic laparoscopy, it goes through all your laparoscopic equipment you should already know. Let's do stuff that's different instead. So practical considerations. The surgical tech should know how to manipulate the uterine manipulator under the supervision of the surgeon. So I'm at the bottom, the very last thing on page 538. The ST should know how to manipulate the uterine manipulator under the supervision of the surgeon. This is where you have to have the medical terms memorized inside your head to where it's second nature and you just follow directions. Because you are holding the handle, they're going to tell you to move that uterus laterally or to move it in medially. They might tell you to dip it down posteriorly or move it up superiorly. Everything they're doing, they're giving you direction. They're not teaching you how to do it. They're saying, figure out how to move that uterus where I need it to be so that I can do my job. That's not something that we can teach you in the lab. That's something that you're going to do for the first time hands-on and learn as you do it. A lot of this job is learning as you do it the first time. So I hope that you are mentally prepared for that type of learning environment. It's difficult, but it makes it very fun too. On 539, it goes through all of the pictures of everything you need for laparoscopic surgery. I will not review that. I will, however, have you take a look at that old school uterine manipulator. So letter B. See how it says acorn cannula? That little tip on the end is what they're referring to as the acorn cannula. So that's actually going to be inside the cervix, and that's what's allowing us to manipulate it on the handle end. Okay, if you look at page 540, it's more laparoscopic pictures, just like 541. I want to look at number 1. So as it starts going through the procedure, I want you to make yourself a note. So it starts surgical procedure on 541. It's talking about putting a handheld retractor in the vagina and placing it posteriorly, and the cervix is going to be grasped with a tenaculum. That's the first thing we're going to do on any vaginal procedure. We're going to put a speculum or a retractor in and then grasp onto that cervix with a tenaculum. After that, we're putting in the uterine manipulator. So that's the whole reason for us grasping it, is putting on that uterine manipulator. Now is the important part for the scrub techs. So procedural consideration. The surgeon's top gloves should be removed and replaced with the proper technique following the vaginal portion of the procedure. A lot of times that's it. We're putting in that uterine manipulator. Everything else is going to be done through the belly, laparoscopically. If that is the case, you have to make sure you have separate setups. So make yourself a note. If we're taking the time to remove the top glove from the dirty section of the case, you just put in that uterine manipulator. That means your other setup needs to be clean. So it doesn't say it word for word in your books. I thought I would point that out for you. So small separate setup, and make sure to have clean gloves ready for your surgeon. So it says surgeon's top gloves. As I've told you before, we will be double gloving. So yes, they could just take that top pair off and work with one pair, but we always want to be double gloved. So have a second pair of gloves ready for your surgeon. Okay, and then the very last sentence, instruments used vaginally must be isolated. So that's your whole purpose of having 2 setups. You have one for the abdomen that's clean and one for the vagina that's considered dirty. Okay, after that, page 542, just a reminder, I'm not going to go through the whole thing. A reminder on number 3, they could use towel clips or coker clamps at the very beginning to grab onto that fascia and get the trocars into the belly, or the Verries needle, as we like to start with on GYN cases. So if you look at number 4, you'll see that they will insufflate with the Verries needle. Hopefully that was all review for you. The rest of it is a laparoscopic procedure, step by step, all review. If you need it, read through it step by step. Now that brings me to hysteroscopy. Very common procedure that you're gonna see. So back table only, no Mayo stand. The surgeon will be sitting in a stool. You'll have endoscopic equipment Again, I'm not saying laparoscopic. We're not putting it in the belly this time and filling it with CO2. We are looking inside the uterus. So hopefully you remember your med terms. Hyster means uterus. We're looking inside the uterus. So look at your last bullet point on surgical anatomy and pathology. Hysteroscopy is used to treat pathologies such as adhesions, polyps, and myomas. The note I want you to add is this allows us to visualize the endometrium. It allows for visualization of the endometrium. Okay. So on hysteroscopy, let me go through what all you will need. Very similar to laparoscopy, but we're using it on the other end here to look inside the uterus. So you still need a scope. You still need a camera, you still need a light cord. What is being traded out is irrigation tubing instead of insufflation tubing. So there is no belly for us to insufflate. We can see inside the uterus, so we just need irrigation tubing. So this is going to irrigate water through it throughout the whole time. So it's going to fill it up with water, and then we can see very well during the case. And then my last bullet point on the slide says lubricant, and that should be right next to all of your dilators, as I've said in class. A lot of times I will see scrubs just put the lubricant on the bottom of the dilators so that they are ready to go. It can cause tissue damage if you're not using enough lubrication. So you want to have ample available in the room also. Okay. If you look at your equipment, instruments, and supplies, I want to point out that they have the D&C instrument tray available. So every hospital is different. They might just have a vaginal tray. They might have a hysteroscopy specific tray. Most hospitals I've worked at just have a D&C instrument tray. You'll use a D&C instrument tray whether you're doing a D&C or not. If you're doing something just vaginal or you're taking out a small specimen, example, this hysteroscopy, they'll just give you a D&C tray. So what you're looking at on this slide is a D&C set plus all of the equipment you need to do the hysteroscopy. So the camera, the light cord, the scope, all of that stuff is extra. You will see in the back of the basket these long biopsy forceps. So that allows them to take biopsies during the hysteroscopy if they see something that they need to biopsy. Okay, that was your hysteroscopy. Now I'm going to go to page 545. And I don't have much to add to this one. Marsupialization, very fun to say, of the Bartholin's gland cyst. So you will see these glands appear sometimes. Let's look at the anatomy and pathology. So your Bartholin's glands, if you don't remember, are the two glands located on the posterior side of the labia majora. These glands secrete the mucus and provide vaginal lubrication. So you need these glands, but unfortunately, sometimes we have to remove these. So I will go over that. Let's look at where it says obstruction. So if there's an obstruction, and this can be very painful for the patient, this can happen from infections and more frequently trauma. If you look at that last bullet point on anatomy and pathology, most of these cysts are asymptomatic. So the patients don't have any symptoms, but an infection can lead to an abscess, and then they have swelling and pain, and that's when the patients come in. And that's when we find these cysts that need to be removed. So because of that, you see the reason is for obstruction, infection, maybe trauma. To you, that should cue you where it says instruments, equipment, and supplies. Culture tubes. Anytime you read the word infection or you hear about your case and they're talking about possible infection, you should know to get culture tubes. Next thing you need are culture tubes, have them ready in the room. So reminder, aerobic and aerobic culture tubes for any infected case. But these Bartholin gland cysts are commonly infected. So if I know I'm doing a Bartholin's gland cyst, then I'll already have my culture tubes ready to go. So again, this is a considered dirty procedure, but we're gonna set it up sterilely and use sterile technique regardless. Okay, you can see a good picture of how they're going to sew up this wound on page 546. So look at those pictures and understand how they will use that technique to sew up after removing this gland cyst. This is one, if you look right under your pictures, letter A and B, this is one where you might have to help retract some tissue. So letter A, retraction of the labia minora and incision into the infected cyst. So when they make that incision into the cyst, there's so much tissue in the way, there's not really a handheld retractor for that type of tissue. A lot of times you're just hand retracting. So they might have you hold the skin, the tissue in a certain way so it's retracting so that they can get to that cyst and get it out. And again, look at that picture to see how they're going to close it. After that, look at your wound classification. Pay attention to all the wound classifications as you're reading through OB-GYN surgery because they do change quite often. So if that were infected, it's going to change to a class 4 because it's a dirty infected case. After that, 547, so a simple vulvectomy. So on this one, you really need to read through the anatomy. That is all I'm going to say to you. I think I give you guys enough hints about what is going to be on the exam. So for simple vulvectomy, you need to read through that anatomy very well. On page 549, you will see what it's actually going to look like in the procedure. So you'll see which arteries they're going to cut and the muscles that are going to be moved out of the way. What I want you to look at is the closure. So letter D, subcuticular closure. They have to put that catheter in the urethra as they're doing the closing process. So for you, the scrub tech, that's telling you, you need to have a catheter up on the field ready to go because that's going to be part of the closure. Okay, so I have something to add on the beginning of 550, the next page. So if you've noticed, your book does skip around quite a bit. So what I was talking about earlier with genital warts, so I was talking about all the different diagnostic things for cervical cancer and that you could breathe that in. I mentioned that same thing can happen with genital warts. They could be cauterizing on that and you could breathe the plume in, and I do not want that to happen to you guys. So it's a reminder to wear that special mask that they will offer you and have in the room to protect yourself. So top of 550 is the second example that I talked about out loud, but I want you to see where it says it in the book too. Ablation of a condylomata, so that's genital warts, is similar to a vulvectomy procedure as far as the anatomy. The differences include, and it goes through every little difference. What I want to do is look at that last bullet point. Lesion with a CO2 laser. Surgical plume is evacuated with care to prevent viral transmission. So this is not just my story that I have heard from other coworkers. This is in your book. These lesions, when they are taken off with heat, so example, the CO2 laser, the LEAP procedure, as I just talked about in your book, anything that's using heat and fire, it's going to produce a plume. I do not want you to breathe that in. So not only are we going to be sucking up the plume like we always do on surgical procedures, we're going to suck up all the plume and we're going to wear a special mask to make sure we're not breathing that in. So CO2 laser, you're going to get a CO2 laser mask that is going to better filtrate what's in the air so you're not breathing in that plume. Okay, had to jump to that as it says it on page 550. So now I will skip over this next case because you can read through it very easily. So labiaplasty. Make sure you read through this one step by step, but I will hit the pathology really quick. So perform to correct labia minora hypertrophy caused by congenital abnormalities. What it's telling you is congenital abnormalities is why we'll do this case number 1, and then it gives you other examples. So repair of tearing, repair of stretching due to childbirth, trauma, sexual intercourse, age, and piercings. When I have seen labiaplasties, they have been from piercings gone wrong. So this can just vary. It could be a very simple procedure. It could be a very involved procedure. It depends on what the reason is for the labiaplasty. Okay, now I am on D and C. So as you have seen now, this DNC tray can be used for multiple different surgeries, but I want to focus on finally just the case, dilation and curettage, and why we will be doing this. So indications, let's look at indications. So I'm on 551, second bullet point. Diagnostic indications for DNC are excessive bleeding, excessive pain during bleeding, cytology specimens that may think that we need to go check something else out, infertility scares, they might want to determine the cause for infertility. There's lots of different reasons. Now let's look at therapeutic. So removing pathology such as polyps, treatment of postpartum bleeding, retrieval of a lost IUD, very common, placement of radioactive beads, so many different things. Let's look at the last section. If the procedure is performed after the 13th week of pregnancy, it is termed a dilation and evacuation. That is what it says in your book. I talked about what I have seen real life for you in the classroom. So when I saw evacuation, I was talking about a different procedure. So I want to point out that DNC is usually done when our patient has had a miscarriage. They're not going to go through the labor process, so we're going to do a DNC and take that products of conception out. So again, your book says D and E if it's performed after the 13th week of pregnancy. That's because that is what's done in other states. So D and E technically is going to be when it's a chosen abortion, when we're actually using that term how you hear it out in the world. You will read the term abortion throughout your book used in different ways. So it's not talking about an abortion that is chosen. This is something different. So again, DNC, typically going to be a woman that's had a miscarriage and is not going to have to go through the birthing process. So we're going to go in and get our products of conception as our specimen. Wanted to point that out so you have the real life versus textbook as usual. Okay, 552, let's continue with our DNC. So look at equipment, instruments, and supplies. DNC instrument set, TELFA for your specimen, and lubricant. I also want to add, you're going to need lots of sponge sticks on this case. So you see one on your paper right there because they're probably good at making more sponge sticks. You will want to be able to make the sponge stick with one hand and do it quickly if you only have one Forester ring forceps to work with. Okay, the actual case, they will definitely be in lithotomy position. I have been in the situation where you move the patient over from the gurney to the bed and the DNC just happens. The specimen comes out naturally on its own. So on these cases, they're still going to put the patient to sleep. We're going to go in and take a look. That's because there's lots of bleeding happening. We want to make sure all the bleeding has stopped and that mom is taken good care of. Okay, page 553, I will go through this procedure. So a pelvic exam is going to be done first. After that, let's go through the procedure. So the weighted speculum is put in first at the bottom. So that pushes down and we can easily see the cervix now. So weighted speculum is in the posterior vagina. After that, you'll see the procedural consideration. Sterile glove is placed over the round weighted section of the speculum to catch any of that blood or tissue. Number 3, the cervix is grasped at the 12 o'clock position with that single tooth tenaculum. Number 4, I flipped up the page to page 554. The uterine sound is advanced through the internal os and the fundus to determine the depth of the uterus. So make sure when you read the sound, it's talking about the uterine sound, the instrument that you learned today. After that, any of your specimen will be put on a TELFA. That's what your procedural consideration says. You will, if you look at number 5, you will have an endocervical specimen. They're going to use narrow curettes for that one and put it on a TELFA. And then if you look at number 6, you'll see the cervix is dilated with progressive series of dilators. So again, I want you to set that on your table from smallest to largest, right next to the lubrication because they will take those very quickly as they dilate. Now you're going to provide a second TELFA because you're going to get a intrauterine or endometrial specimen. They will almost always use that term, endometrial specimen. Okay, after that, you'll see number 8, actually, we can skip to that, curetting. So endometrial, again, curetting, if you need to add that word in, is advanced into the uterus, and the endometrium is scraped in that same manner as the cervix. So we are curetting 2 different tissue types, and we're getting 2 different specimens. So endometrial and endocervical tissue. Okay, that brings me to the end, actually, looking at number 9. So after they withdraw all the instruments, they're done with the procedure. There's no closing, right? So you need to be prepared to count your very small items very quickly. So as soon as you get those specimens and they're bringing everything out, you need to count those Ratex and any other countable items you have on the field. After that, the operative area is cleaned. That's usually you. So the scrub tech usually does all the work after the surgeon leaves the room. So they finish the procedure, they're out. It's you with the patient all still draped and covered in betadine. So you have to get a wet and dry lap sponge and really clean them very well. It's hard to get all of that iodine prep off of these patients while they're in the lithotomy position, but if you've ever had surgery and you've woken up and still had some prep residue on you, you know that that's very itchy and uncomfortable. So you want to take the time to clean your patient properly. That's part of your job as a surgical tech. So you'll take the drapes off, your patient is left naked, you clean them very well, and then you help the nurse take them out of lithotomy and back into supine position so we can wake them up. Okay, look at your pearl of wisdom at the bottom of that page. Very important. Have extra TELFA and specimen containers in the room. Make sure you're communicating well with your circulator too. Okay, 555. You can finally see the cervical biopsy now. Again, your book skips around. It's because of all the charts that they put on the inside, which are great, but that forces me to skip around in your lecture also. So I'm skipping to where we were talking about cervical biopsies. So 555 at the top of the page, know the names of your biopsy forceps. So like your Tistler is one example. You should know both of the names of your biopsy forceps and know that they're going to use that DNC tray with it. Both of these forceps, they describe them in books as pistol grip gun forceps. Let me grab one. So they consider this Tischler a pistol grip gun handle. So it's just because of the way the handle is. So I wanted you to hear that term. So if you hear it again, you recognize those as your biopsy forceps for cervical biopsy. Okay, now let's talk about what we're gonna do as far as cervical cancer goes, since we're talking about cervical biopsy. So you have 2 options and you've already learned them both. This is review for you. So acetic acid or Lugol solution can help identify the abnormal tissue. So they're going to use a cotton tip swab with acetic acid, and they're going to apply that to the outer portion of the cervix, and that's going to stain the abnormal tissue white. So separate that portion. Acetic acid turns the bad tissue white. So that's going to make it light up so you can see it very easily. Separate from that, the Schiller's test. The Schiller's test uses brown-colored Lugol solution. It's brown because it has iodine in it, so it's got some iodine in it, Lugol solution. When this is applied to cervical tissue, the tissue that retains the brown color is normal. And the tissue that did not take up the stain and does not stain is the abnormal tissue. So these are both telling us what is cancer and what is not. There are 2 different tests that are showing 2 different things. So please read through that. Make sure you don't get the 2 confused. So again, acetic acid is going to turn the abnormal tissue white. Acetic acid white. Lugol solution has iodine in it. So it is brown, but it's taking up the dye differently. So the tissue that did not take up the stain and does not stain at all is the abnormal tissue. So this helps the surgeon identify the tissue in which to remove small pieces of abnormal cervical tissue to be sent to pathology. So they're going to do one or the other test, acetic acid or Lugol solution, and that's going to tell them where to take their cervical punch biopsies from. Okay. Now I will go to page 556, oophorectomy. So make sure you know your med terms. So when you read oophorectomy, you know that we are removing the ovaries and not the tubes. So read through this anatomy, pay special attention to the broad ligament, know that that provides the main support of the ovaries. So you should still know all your other ligaments, but I want you to pay attention to that broad ligament. Okay. Actually, I don't have much to add on this one. So if this is done open, let's look at your surgical procedure. If it's done open, it's a laparotomy. We're going to remove those ovaries like an open belly case. This can be done laparoscopically. So it would say laparoscopy instead of laparotomy. And we're going to be removing the ovaries laparoscopically. So I wanted to point out to you that even though this is a laparotomy, so it's open, we'll count instruments, that's not always how they'll do it. You have the option to do it laparoscopically. So we can get to all of our GYN anatomy and organs through the belly. So if we can, we try to do laparoscopic. So oophorectomy, removing the ovaries, not the tubes. That brings me perfectly to salpingectomy. So salpingectomy are the tubes. So let's look again, surgical procedure, laparotomy is performed. So I'm telling you again, this could be done laparoscopically. So it would say laparoscopy for salpingectomy. So a laparotomy is performed, window is created. Look at number 3. The tube is separated along the entire length of the broad ligament attachment. So that part is important. That's the time-consuming portion. So we are going to do the same procedure on both tubes if they're both being removed. So look at number 5. I'm pointing that out because not always are we going to remove both tubes. There might be a specific reason we're removing the tube. Maybe there was an infection, maybe there was a malignancy. So make sure you know the information before you do your case. So know if you're removing both tubes or just one. If you're removing both tubes, make sure you label them correctly. Okay, and then what I'll add on to the end of that is more commonly you will see salpingo-oophorectomy. So they combine the two, salpingo-oophorectomy. Okay, that brings me to page 558, endometrial ablation. So what I want to point out is that we might use the laser on this one to ablate this tissue. Basically, these patients are coming in with chronic bleeding or they are actively bleeding at the moment. And so we're going to go in and ablate all of that tissue, char it to get it to stop bleeding, to help our patient not lose so much blood so quickly. So look at your options, equipment, instruments, supplies. So options for lasers, they could use the YAG laser or the argon laser. What I want you to add is that they could use that CO2 laser. CO2 laser. I also want to point out that this goes hand in hand with a hysteroscopy. So I can go right back to that actually. So your setup is going to look like this. You're going to be doing a hysteroscopy, but in addition to this, we are going to be ablating that tissue. Because we are ablating that tissue, we have to use a certain solution for ablation. So find in that same section where it says D5W solution. So this solution is going to be used for balloon endometrial ablation. So it's basically hot dextrose water that is going to be helping us ablate this tissue. So all of this endometrial tissue is bleeding. Our patient has constant chronic bleeding, and we need that bleeding to stop, so we're going to ablate all of that tissue inside. Okay, DNC instrument set if performing a balloon endometrial ablation, which is typical. There are other ways to ablate it, like I pointed out, like your CO2 laser. The different ways to ablate that. What I'd rather you see is the purpose. So look at your surgical procedure. So look at laser. Laser is what I want you to focus on. Laser endometrial ablation. The laser is going to destroy the endometrial lining of the uterus, causing scarring upon healing. So again, we are lasering, charring in any way, whatever form of cautery the surgeon wants to use. We're charring all of that tissue so that that bleeding can stop. So no more endometrial bleeding for our patient inside the uterus. Okay, that brings me to 559, myomectomy. So you guys saw the myoma screw today. So you saw what that looks like. And a myoma gets pretty big. What I want you to add is on this first section, actually. So where it says surgical anatomy and pathology, a myomectomy is excision of uterine fibroids called myomas. So removing the fibroid tumors of the uterus, that's what we're doing. So if you need to add in those words, you can. Removing fibroid tumors of the uterus. That's what we're doing in a myomectomy. Looking at your practical considerations, I want you to read through all of them and understand how we can do a myomectomy in different ways, like laparoscopy, not just vaginally, abdominal approaches. I want you to read through those bullet points. I want you to focus on the one that says, myomectomy is performed when preservation of the uterus is necessary. So that just means for fertility. So if you need to make that note, go ahead. Myomectomy is performed when preservation of the uterus is necessary. That's telling you, if it was a different patient, we would just do a hysterectomy. This patient clearly wants to keep their uterus for fertility reasons. So we could do a hysterectomy so that we don't have to later on come back and do a hysterectomy and remove the uterus, but these patients are wanting to hold on to that for fertility. So keep that in mind on these cases. Okay, because this one's talking about an abdominal approach, I will tell you this is a time where you might get to use that O'Sullivan-O'Connor retractor in the abdomen. If you flip it over to 560, you'll see that that corkscrew that I showed you is just one way to remove the myoma. They can clamp other instruments on it. So you can see in 560, they have something sharp. I've even seen them clamp a towel clamp onto a myoma. So anything that can really hold on to that tough myoma tumor, they can clamp on there. Okay, that brings me to hysterectomy. So because there's so many different ways to do it, I have had students before ask me questions, and I wanted to make sure there's no confusion between the different kinds. So I created the slide for when I did CST prep for GYN surgery. So this clearly separates, both with visuals and typed out for you, the difference between a total abdominal hysterectomy versus a regular hysterectomy versus when they say they're taking the tubes and ovaries. So you have heard now salpingectomy and oophorectomy. Hopefully you remember I just told you that those two can be combined and are more commonly combined. So on this last one here, you see salpingo-oophorectomy. That just means we're removing the tubes and the ovaries. So don't be overwhelmed by these terms. Be confident in your medical terminology and show that confidence when you have to answer these questions quickly. You want to be able to pop an answer when a preceptor says, we're doing a total abdominal hysterectomy with BSO. What does BSO stand for? You should know that it's bilateral salpingo-oophorectomy. So you want to be able to answer these easy questions correctly because they will consider these easy questions. If it's not critical thinking, it's an easy question. Okay, total abdominal hysterectomy. So page 561. TAH is what it's going to say on your OR board. Total abdominal hysterectomy. So hysterectomy is removal of the uterus, but this one is total. So surgical removal of the uterus and the cervix. So I want to point out the cervix is connected to the uterus, yes? So it can come out all at once, but it doesn't have to. So pay attention to the little dotted lines that separate what is removed in each section. So total abdominal hysterectomy, this is a big abdominal case. You'll have lots of lap sponges. We usually use the Bookwalter retractor to really get in there so we can remove our uterus through the abdomen. Another time where they might use that O'Sullivan-O'Connor retractor, but like I said, we use the Bookwalter retractor. Keep in mind with this one, the counts. On the total abdominal hysterectomy, the counts are very important because you have an extra count. You're closing the uterus. That's a whole nother cavity. That means when they start closing the uterus at any point on a C-section, you have to do a count, right? So if they, for some reason, aren't removing total, they're not doing total hysterectomy, you need to be aware of the count. So let me go back to this one, total hysterectomy. So we're removing the uterus and the cervix. So there's not another layer to close on this one. I just wanted to point that out for you so you don't forget. So on this one, I want you to read through the procedure, but I told you the instruments that they're going to use to do these ligament clamping and cutting. So hopefully you remember that we're going to use those hysterectomy clamps and sometimes the Ballantine Haney clamps on these cases to clamp onto these ligaments, especially the round and ovarian ligaments, so that we can make our cuts to remove our uterus through the abdomen. Okay, we will see, look at number 7. So it goes through the whole case step by step. You should read it. When they're doing blunt dissection on these cases, sometimes they're going to want to use a sponge stick. So I want to point that out for you. So even though I told you sponge sticks are more for vaginal cases instead of open belly, we can use it open belly also. So think of it like general surgery on this case because it's a big open belly case. Even though it's GYN, it's like a big open belly case. So you'll still need sponge on a stick for these. And then another procedural consideration under number 8. Be aware that they have Haney needle holders and that they can be used on these cases. The jaws are curved and the needle is loaded with the point projecting behind the convex of the surgeon. So it's telling you that they used curved needle drivers, Haney needle drivers on these cases. My experience with GYN surgery, if we're in the belly, the open belly, they can still see. They don't always need that curve on the needle driver. So I want you to have it in your mind that if it's open belly, you can use a regular needle driver. If the surgeon asks for a Haney needle driver, of course, give them what they want. But if it's vaginal, that's when we need that curve on the needle driver so we can really get those angles and see into the dark spaces that we can't see as well. So Haney needle drivers are used on vaginal portion of the case, but know that it's an option for the open belly portion too. Okay, this one actually has great pictures of what it's going to look like when they cut the ligaments and step by step of what they're doing. So look at 563, TAH, total abdominal hysterectomy. Look at letter B, division of the round ligament. So that's one of the big cuts that they're making. They're cutting that round ligament. Every time after they're cutting, they're putting suture on these ligaments. Because even though they're ligaments, we have all the tissue around it that's constantly bleeding. You'll see next thing they're going to do is the uterine artery is clamped, and then that broad ligament is going to be exposed. But as every time after you see a clamp get put on, they're tying a suture right after. So hopefully you remember your pattern from general surgery, clamp, clamp, cut, tie. It's going to be the same procedure on these cases. So even though it's GYN, think of it as a big general case. Okay, you can see on 564 more of what those cuts are going to look like, and then what it looks like when they sew up the vaginal cuff. So they're taking that out and then sewing up the vaginal cuff, and that's letter F. Okay, let's go down. It's talking about they're cutting the ligaments, but you can read through that step by step. As they're cutting the ligaments, let's go to number 13. Number 13, so our uterus is still in. We're going to use curved clamps to place bilaterally to incorporate those uterosacral ligaments. The uterus is going to be freed and then removed after that. So what I'm pointing out to you is those uterosacral ligaments are clamped last. Uterosacral ligaments are clamped last. Right after that, we get to free the uterus and get it out. Procedural consideration. These instruments are considered contaminated since they may project into the vagina. The Mayo or Jorgensen scissors are commonly used. So what that's telling me is when they make that last cut, that might be on that vaginal cuff, that we're going to isolate those instruments. So you might have, even though it's completely abdominal, you might have an extra Mayo stand or in a separate area where you put your contaminated instruments. Okay, after that, bring up a specimen container after passing those scissors. They should be isolated or removed from the field following the use, just as I said. So if you don't remember, you should go back and look at your Jorgensen scissors in your orange book. These are those heavy right-angled scissors, and I want you to recognize it as that. So if you see that written, you'll know we're talking about Jorgensen scissors. So heavy right-angled scissors. Okay, that brings me to number 14. Now you have the vaginal cuff left over after we've removed that uterus. So we will now close that. So close with interrupted sutures. Okay, one more time, reminder, instruments used to close the cuff, just like cutting at the end, are going to be isolated because they are contaminated. So any instruments used to close that vaginal cuff is going to be isolated and contaminated. Okay, after that, 565, they're going to irrigate really well, check for hemostasis because this is a very bloody case, as I said, and counts as necessary. Look at your wound classification. So class 2, clean contaminated, and that is because of the vaginal cuff at the end. Because of that, we might or might not have some instruments get contaminated, right? But look at your line, it's kind of hard. Look at the line anywhere on this anatomy. We're in the vaginal canal, we go through the cervix, and then all of a sudden we're in the uterus. So think about the path we have to travel. If we go through the vagina, yes, that's considered dirty, but we're open belly, we're going through the belly and we're going to the uterus. Once we take all this out, we have to sew up right here. So it doesn't matter our approach. It doesn't matter if we're approaching it through the belly. If something is touching tissue that's considered dirty, which the vaginal cuff definitely is, then we want to separate and isolate those instruments because they are considered contaminated. If you guys have any questions on that part, what's clean, what's not, what's contaminated, what's not, please ask me. We want you to understand what's sterile and what's not on these cases more than anything. Okay, this part, the pictures, I want you to go through it just like your general surgery. It went through a laparotomy step by step. Same thing, read through this step by step with the anatomy, focusing on that broad ligament. If you look at example on page 567, plate number 15-7. So it's talking about the suspensory ligament being identified. That suspensory ligament has another name, infundulopelvic ligament of the ovary. If you find something like that in your book and it has two names, make sure you know both names. They can use them interchangeably. Okay, so I want to point out on 568 what those scissors look like. So plate 15-13, that last cut is made with the Jorgensen scissors. This is used to dissect around that cervix. So look where they're cutting because that's that vaginal cuff. We are going to consider that dirty. So not only are those Jorgensen scissors dirty, but on the next picture, plate 15-14, those Alice's, the needle drivers, the actual needle, anything that touched that vaginal cuff needs to be separated because it is contaminated. Okay, Make sure to read your pearls of wisdom, very important. Now let's go to vaginal hysterectomy. So hysterectomy itself just means surgical removal of the uterus. This one's done all vaginally. So not all women their anatomy doesn't work well enough to let us all do it vaginally. That's why we have so many options. So this one's just vaginal, and after that I will go into laparoscopic assisted vaginal hysterectomy. I want you to separate the three. So we just went over TAH, total abdominal hysterectomy. Next, I'm going to go over just vaginal hysterectomy. So your patient's going to be on lithotomy. You start with that Avard weighted speculum, and after that you put in your two side wall, as they typically call it, but right angle retractors. This is what you will be holding a lot during these cases. So either a right angle Haney retractor or a Deaver. After that, I want to point out number 4 on page 570, a tenaculum or a Leahy clamp can be used. So you know after today that there are single and double tooth tenaculums in addition to a Leahy clamp. There's just many different options because surgeons have different preferences. So make sure you read your preference card, ask your preceptor what your surgeon's preferences are. Okay, so we're still hitting the same anatomy, just a different approach, right? Much harder to see looking through the vaginal canal. That's why we're retracting so hard while we're passing instruments. It makes it a little more difficult, but think about the recovery for your patient. If they can do it all vaginally, nothing abdominal, that's going to be quicker recovery for your patient and better for them in the long run. So if you can do it vaginally, that's what we like to do. So again, we're cutting and clipping the same things as you go through. I want to point out something that is different. There's something that's done first vaginally instead of last. So look at number 7 on page 570. So this time the uterosacral ligaments are doubly clamped with Haney clamps and cut with those Mayo scissors and ligated. After that, the ends of the ligatures are not cut but are left long, and each is tagged with a cryo clamp. So they're tying it and they're tagging hemostats or cryols on the end of it. What I want you to pay attention to is on the TAH that we just learned, total abdominal hysterectomy, we do those uterosacral ligaments last. It's because we're seeing the anatomy from a different view. Instead of from the abdomen, we're seeing it from the vagina. So from this angle, we are going to clamp and cut those uterosacral ligaments first. So make yourself a note. This time it's done first, not like the TAH, where it is done last. Okay, because this one's done all vaginally, you don't have to separate your clean and your dirty instruments. They're all considered dirty. Okay, let's look at LAVH then. So your book says laparoscopic hysterectomy. I would like you to make a note to the side, LAVH. That stands for laparoscopic assisted vaginal hysterectomy. So as I said, not all hysterectomies are able to be done vaginally. That's because we have to free up all of this tissue and cut the ligaments to get it out. You can't always see on every patient. We've got different size people, different size uterus, different angles of tilts of the uterus and the cervix, so many different options. So that's why the surgeon knows the patient and they can direct them into the correct type of hysterectomy that they need. What is so common is an LAVH because it's hard to get it all out vaginally on some patients, as I said. So they'll go in laparoscopically, make their cuts, free it all up to where all we have to do is put in some retractors and go in and pull our uterus and cervix out. So our specimen can be pulled out vaginally. Okay, so LAVH, hopefully you wrote that on there. I want to point out the equipment, instruments, and supplies. They're going to put them in the Allen or yellowfin stirrups. What I want you to add is they're going to be in low lithotomy, not just lithotomy. Think about where those legs are. They're way high up in the air. If we're working on the abdomen, those legs might get in our way. So all we're going to do is when we position, we're going to lower the legs down so that the legs aren't in our way during the abdominal portion of the procedure. Sticking with equipment, instruments, and supplies, look at everything you need in the room. You need your laparoscopic equipment in the room, but you also need everything to do an abdominal hysterectomy available. That means they could go at it laparoscopic and it not work. Maybe they have some adhesions, maybe they have some other pathology that is preventing us from freeing it up that way. So we might have to just switch, make an incision, and convert to an open TAH. Make sure you understand that this could switch from laparoscopic to open, just like all laparoscopic cases. Okay, so your position, again, if you're looking at pre-op preparation, is in low lithotomy. They could be general or spinal anesthetic. What I want to point out is your draping. So you'll get an LAVH drape, but to get started, you have to put a drape underneath their hips. So find where it says under buttocks drape. That is the technical name of the drape. You'll see it on the outside of the package and everything. It looks like a Mayo cover, but the first thing you're going to have to do after the prep is put this under buttocks drapes under the hips of the patient. So this is what I was talking about, where you have to get really close in contact with your patient to help with the positioning and draping and prepping. After that under buttocks drape, then they'll put some towels down, and the LAVH drape includes leggings to cover those legs. Okay, after that, you can see some of the different devices that they'll use to still cut and clip the same things, ligate the same anatomy. But when it's laparoscopic assisted, I'm on page 572, you'll see that they'll have to use a stapling device on these ligaments. That's because it's done laparoscopically. We can't go in there and clamp, cut, tie. So instead, we are using different devices to cut and coagulate and sometimes staple across that line. Okay, I think I just want to hit a couple things on this one. On your LAVH, let's go to page 573. I want to point out that we're starting with a uterine manipulator. So right now I have a table with vaginal instruments right here because I see my weighted speculums. And then over here I have all my laparoscopic equipment. That's for the belly. They're separated for that reason and they will not get mixed up. They zoomed in on these gown and gloves because they want you to have extra gown and gloves because of this reason right here. They're starting with the uterine manipulator. We're starting the case dirty. So because we have to get in there and put that uterine manipulator in, the first thing they're going to need is a new set of gloves because they're going to go to the abdomen and start working and freeing up those things. So the idea, unfortunately, on an LAVH is that the surgeon goes dirty to put the uterine manipulator in, clean for a long time to free up and make their cuts, do the surgery, and then at the very end, dirty again to pull the specimen out. So you have to really be vigilant, watch your surgeon, communicate well with them, remind them when it's time to change their gloves and things like that. You can't make a surgeon do something that they're supposed to do, but you can give them a friendly reminder. I have been known to friendly remind multiple times to the point where it's nagging, but it works because my surgeon changed their glove. So be careful with doing that as a student. Of course, you want to be very respectful the way you word things, but most of the time, if a surgeon is forgetting to change a glove, they're going to thank you if you're helping them out. Okay, so again, separate setups, extra gowns, and gloves. So we are starting with that uterine manipulator, so we're dirty. We're going to change gloves, go up to the belly, and do our laparoscopic case. GYN surgeons usually use that Very's needle instead of the Hassan technique, but we're making the same cuts as we go through. Same cuts all the way through. Okay, look at number 15. The uterus is grasped and pulled in front of the vagina. So we're done and made all of our cuts and we're pulling it out. Procedural consideration. The surgical team now begins the cervical portion of the procedure and should not cross-contaminate by re-entering the abdomen unless gown and gloves are changed. After that, number 16, using that uterine manipulator, the uterus is removed through the vagina and the peritoneum and the vagina are closed in the manner preferred by the surgeon. So right there, manner preferred by the surgeon. What it's telling you is that the vaginal cuff can be closed vaginally or through the belly. So abdominally or vaginally is how that vagina is going to be closed, or the vaginal cuff will be closed. So that is up to the surgeon's preference, and you need to communicate and know their preference so you're ready for that. Okay, after that, let's flip over. It goes into robotic assisted laparoscopic hysterectomy. So I will tell you that a robot, or I'll tell you again, a robot is a giant laparoscopic case. That's all it is. So if you see a robotic case and you have already done a laparoscopic hysterectomy, you already know the procedure. It's going to be done the same way, just with that robotic assisting them. So you might see more precise cuts, more cool tools because we're using the robot, but we're still going to be making the same cuts step by step. So make sure you read through that first case of hysterectomy. Okay, let's look at 575 at the bottom of the page, uterine radiation seeding. So what I want you to pay attention to on this part is what the purpose is. So these seeds are implanted either temporary or permanent, I've seen both, to treat uterine cancer. So these can help shrink the tumor preoperatively for a tumor that's non-resectable. So that is how these surgeons make these decisions. You will just kind of see the case and you go in and do the case. You might get to ask them questions about the patient, but typically if you ask them like, why are we doing radiation seeding instead of removing this tumor? That's going to show that you have interest in the case. They're going to tell you more details. They'll probably be more likely to teach you more. So little things like that, please ask questions. It will help you in the long run. They will see that you care and you want to learn more. Okay, so on this case used for uterine cancer, I want you to also put cervical carcinoma. So it's used to treat uterine or cervical carcinoma. Okay, after radiation seeds, I want to look at radical hysterectomy on 576, radical hysterectomy. So radical hysterectomy is the in-block removal of, ready for it, bilateral ovaries, tubes, the uterus, supporting ligaments, upper third of the vagina, and any associated lymph nodes. So we're removing a lot of tissue. This is always for malignancy. So an extensive malignant tumor that we are trying to stop it in its tracks before it spreads anywhere else. So see where it says in block. Hopefully you already know this term, but if you don't, here's where you can make your note. So the in block removal, what it means when it says in block, removal of the entire tumor without violating the capsule. So removal of the entire tumor without violating the capsule. Hopefully you understand what in block means if you didn't already, and what all is going to be removed. So the only note you should have to add in there is above where it says ovaries and fallopian tubes, know that that is bilateral. You always have to point out laterality on these cases, as I've said before. So you don't want to just put ovaries. You got to be specific, right and left or bilateral. So bilateral for both of those. You can see we're removing a lot of tissues. So this is going to be a very long, extensive case. So be ready to be in there for lots of hours getting all of the specimen out. What I want to point out is because we're removing a big portion of the vagina, the closure is going to be different. So you're going to have different types of suture. And you also are going to have more instruments that become contaminated. So you need a big setup for all your dirty instruments and then separating all your clean abdominal instruments. It's even more important to separate things on these cases. You have it separated, dirty and clean. You should already know that part. I've stressed that enough. It's even harder when there's cancer also. Because yes, we're doing dirty, clean as in vagina and the abdomen. Now we're also adding dirty as in cancer versus all the stuff that's still sterile in the abdomen. What I would do on radical hysterectomies to help with this is I had a vaginal table, abdominal table, and then a cancer table. So or Mayo probably if you don't have enough room. So I have a little Mayo to where anything that touched cancer and the specimen is going to be put on that Mayo stand. So that way we're not going to reuse those instruments and we don't run the risk of spreading those cancer cells on those instruments to other portions of the body. That's just another reason why we irrigate so well at the end of every case. We want to wash out anything that's in there and get it out so we're not spreading it around. Okay, so radical hysterectomy, you can read through that. You'll see that we're removing a lot more tissue, but the hysterectomy portion is still the same. What I want to point out is because we're removing so much tissue, look at number 11 on page 577. Because of all of this, we're going to use a hemovac drain to drain some of this fluid out from the case. Well, that runs me perfectly into pelvic excineration. This is an even bigger procedure, hours and hours on this case. So I want you to see what they're removing in block. So we're also removing the rectum, distal sigmoid colon, the urinary bladder, ureters, ovaries, fallopian tubes, uterus, cervix, all of the vagina, pelvic lymph nodes, muscles, perineum, and iliac vessels. So all of this stuff is being removed. That's a lot for you to remember. What I want you to see is that this is affecting the bowel too. So we're removing GYN anatomy, right? In addition to that, we're removing some general surgery anatomy because this has spread to those areas of the body. So we are removing some colon and some rectum, different areas of the body. Because of that, we're going to need an ileostomy and a colostomy. So see where it says permanent ileostomy and colostomy are created. That's the part I'd like you to focus on, because you're not going to remember every single piece that's being removed on a pelvic excineration. So read through it, understand we're removing so much tissue. This is performed for chronic cervical cancer that is resistant to all the therapies that we've tried. And because the therapies aren't working, we are going to eliminate the problem by removing everything that we can. Okay, so I want to add one more thing down at the bottom here, preoperative diagnosis. Additionally, the psychological state of the patient is going to be taken into consideration because they need to be mentally prepared for the physical changes, the loss of the vagina, and having an ileostomy and a colostomy bag. This is life-changing for our patients. You can look at your equipment, instruments, and supplies. It's like everything you need for an open belly case, plus vascular, plus bowel. So you need GI staplers, things like that. And then everything you need to make an ileostomy and a colostomy at the end. Very long, extensive procedure. Looking at practical considerations, it goes into how it's a lengthy procedure. Make sure that your patient is well padded and taken care of because their body is dead weight at the moment. It's going to be pushing onto those bony prominences. So we don't want to have any red marks or ulcers when they wake up from this surgery. So you will be in here for a long time. Okay. After that, I'm not going to go through the case step by step. I'll point out what is different. So they will be looking for signs of metastases everywhere on this case, first of all. So they'll be really checking out the liver, the kidneys, just looking it over very well to make sure the cancer hasn't spread so that they can notify the patient if it has spread more. Let's go to the bowel section. So number 4 on page 578, the sigmoid colon's identified. They're going to use intestinal clamps just like in general surgery, and a knife and a GI stapler. So you need to use bowel technique is what I want to point out there. Make sure you use bowel technique and you're separating your dirty from your clean instruments. On 579, it's reminding you that we're so deep in the abdominal cavity, deeper than usual, you need long and deep instruments. So after they have transected so much tissue, I want you to look at number 17. Here's where they're going to make our ileostomy, and I want to point out your ileostomy is on your right side of the body. So we just did general surgery, so hopefully you understand your anatomy and why it would be on the right side of the body. But your ileo pouch is what they're going to call it. That's going to be created. So let me read number 17 to you. The ileostomy is created on the right side of the abdomen by creation of an ileo pouch and the ureters attached to it. So it's kind of crazy. They're attaching, because there's nowhere for it to go, they're attaching those ureters to that bowel. So that can, change a lot of things for our patient. That is something that I had not seen before until I did this case. So again, they're going to call it an ileo pouch. They're going to create an ileo pouch, but the ureters are going to be attached to the ileum, and the ileum is going to, they're going to make a bag out of it, just like your colostomy, so an ileostomy. So the patient is having their bladder drained, their ureters through that, the ileostomy, and then their colostomy is taking all of their fecal matter, and they can empty it out that way. In addition to all of this, look at number 18 and 19. They could give them either a J tube or a G tube to help with everything that's going on. So example number 19, the G tube, gastrostomy, that feeding tube you learned about, is placed into the stomach and anchored, brought out through the skin and sutured into place. So they know this patient just had major work done on their bowel. They're going to need a feeding tube for a while. So depending on where they need that nutrients to go, it's either going to go to the jejunum, a junostomy tube, number 18, or number 19, a gastrostomy tube. Both are feeding tubes that are going to be placed into, one into the stomach and one into the jejunum. Okay. Again, really big case. Flip it over, page 580. We're going to end with a colostomy created, and that's going to always be on your left side. Okay, this one, look at all the complications. That kind of makes sense with how involved the procedure is, though. Mortality rate, postoperative SSI, hemorrhage, nerve damage, postoperative pain. So these patients get a lot of counseling so they can really make that good decision on whether they want to have this procedure done or not. Okay, that brings me to page 581. And this is an A&P repair. So I've talked about this one a lot in class, anterior and posterior repair. You need to know the terms cystocele and rectocele, two very common things that happen to women. So cystocele, and a rectocele are herniation of the bladder and the rectum into the vaginal vault. These could be singular or it could be both. So you might have a cystocele and a rectocele. Make sure you know the difference between the two. So know why this can occur also. So it may occur after connective tissue and muscles that support the uterus become weak. So after childbirth, after menopause, different things like that. But that's why we want to keep those pelvic floor muscles strong so that we don't have a cystocele or a rectocele. So hopefully now you truly understand the importance of keeping your pelvic wall strong. After that, let's look at, your third bullet point on the surgical anatomy and pathology. Cystoceles are associated with urinary incontinence. So I want you to write a note out to the side, bladder sling. If you have urinary incontinence, you have a cystocele. that means you're going to need a bladder sling to repair that. So that sling will hold up that bladder so you won't have that urinary incontinence as much anymore. So both of these are going to appear as a bulge in the vaginal wall to the surgeon. So they have to investigate to see if it's a cystocele or a rectocele. The cystocele is going to be a bulge anteriorly, whereas the rectocele is going to show posteriorly. So that should help you separate the two. So again, cystocele anterior, rectocele posterior. And again, your cystoceles, because they are associated with urinary incontinence, that should go hand in hand with getting a bladder sling. Okay, after that, I want to point out equipment, instruments, and supplies. On this one, you'll need lots of Alice clamps, specifically Alice ADAR clamps, and you will need a catheter to put in at the end of the case. If you saw that on any other GYN cases, I want to point out this means on your field. You're used to seeing, or you will be used to seeing, catheters put in before the surgery. This means we want a catheter on our sterile field, so as soon as we're done with the surgery, the last thing we do instead of a dressing is put in a catheter. So inner dwelling catheter. Okay, after that, let me skip around but go through this procedure. So on these repairs, I want to point out that you need lots of Alice clamps available. So look at number 3. Alice clamps are applied as a dissection process. The surgical tech should have ample number on the field. If it says it more than once in your book, it's probably very important, right? Look at number 4 also. So the technique that's going to be used here is blunt dissection with gauze wrapped around an index finger. Make yourself a note. You're going to unfold a Raytech specifically for this A&P procedure, and a preceptor would expect you to know this. So completely unfold your Raytech, unfurl it. They're going to wrap it around their finger and use it as a blunt dissector. So you'll see a lot of finger dissection instead of instrument dissection on vaginal cases, especially this A&P repair. Okay. So flip it over. You'll see what this repair looks like. So we are cutting across the incision on A. B, we're making the cuts in that vaginal mucosa, and we're clamping those Alice clamps on. So now you can see why we're going to have so many. Look at the surgeon using their finger as dissection on letter C. All of those Alices are not holding themselves up. So you will be holding multiple Alices up. I like to loop them in my fingers in one hand so I could hold up one side and retract for the surgeon as I passed instruments. So I probably had 4 Alices looped around my fingers trying to retract back in the correct manner for my surgeon. Definitely have to be happy to multitask on these cases. Okay, and then after that, you can see in letter C, they're dissecting it around, right? So blunt dissection of the vaginal mucosa and cervical fascia. Now look at letter D, completion of caliplication not always required. I want to point out that that's not always required and skip to letter E on page 583. So anterior repair, E, excess vaginal mucosa is excised. The lower portion shows the vaginal cuff and plication technique used on the cervical fascia. So E is what I want you to really look at, where they're making those cuts. I want you to understand where the vaginal cuff is after you read through all these different procedures. So you've seen it all the way from TAH all the way to here at the end of your chapter. So it looks different from different angles abdominally versus vaginally. Here you're really understanding the vaginal cuff because you'll see it sewn up. Okay. So lots of suture on these cases. I will go over how to pass that suture with one hand because you'll only have one hand available because, as I said, you'll be retracting with those Alice clamps. But after they do their anterior or posterior, let's say both, repair, that's when they're going to put in a bladder sling if it is a cystocele. Because the idea is that bladder is laying down too low. We can do our repair, but we still need something to push that bladder up. So that's where you'll see a sling be put in. So it's usually a sling of mesh, like in a little U shape, and it goes under that bladder and just hoists it up so that the bladder isn't hanging too low anymore. Okay, if you look at page 584, you can see your posterior repair. So this one bulges in the posterior vagina and it's considered a rectocele. Still, same idea, we're blunt dissecting with our finger and a Raytech. We're using lots of Alice Adar clamps. So a lot of the same instruments, same order, but different seals. So know the difference between a rectocele and a cystocele. You'll see on page 585, it hits again that you need several Alice clamps to retract those mucosal edges. All of these sutures I want to point out on number 16, because you're seeing all of these sutures on page 584, letter D, you see all those sutures. I want to point out these sutures are progressively tied and cut. So that means as soon as you pass a suture, they're going to tie it and cut it. So you're moving very quickly and you usually only have one hand. So you want to be able to load suture with your left hand if you're right dominant, and same thing with cutting suture. So this is something you're going to want to practice with whichever your non-dominant hand is, because you do not want to be in this situation for the first time trying to load a suture with your left hand. A little too much pressure with the surgeon staring at you. Okay, so this is your anterior posterior repair. Make sure you read through the whole thing. I want to stop at number 20. So on all of these GYN procedures that are vaginal, I want you to see that the dressing is the same. Perineal pad dressing is applied. They usually have mesh panties that go on the patient afterward. So again, you're working with dead weight. Your patient is completely asleep and you're putting on that dressing with the nurse. So this is a very physical job. I hope you're ready for that. Getting a patient that's dead weight out of lithotomy into supine, and then somehow maneuvering one leg at a time, putting on mesh panties with a peri pad is what they're going to call it, is very difficult and very physical. So I enjoy doing GYN surgery. The cases are obviously necessary, but the patients tend to be thankful too. And because of that, you see the patients a little more awake than you do on other specialties. So as you're reading through, pay attention to what type of anesthesia is being provided for them. But I think the most important part of this chapter that I want you to understand is vaginal cases are considered dirty, abdominal cases are still sterile and clean. You're going to have so many that are both abdominal and vaginal. So make sure you understand that you need separate setups. Anything that is sterile needs to stay sterile for the abdomen. So if you have any questions about GYN surgery, please send me a Facebook message, send me an email, something that you don't understand, I'd be happy to go over it for you. So send me any questions you have, and that is the end of OB and GYN surgery. I will see you guys tomorrow. Have a good day.